All right, we've had a few more join. I'll kick us off. Thanks everybody for coming to our June meeting. We have another topic that was like a hot button item, one that people wanted right when we took our initial survey related to PED CoCM. We're hoping for a nice open discussion today. Ben's going to lead us off with a Menti survey to help organize thoughts and gather perspectives. And we'll have opportunity for just cross collaboration and discussion. We're wanting to hear both what's going well and what's challenging in the PED CoCM space. Some of the things that came up in terms of area of interest from our initial gathering of insights from this group were dilemmas that people are facing related to PED CoCM, whether those who are doing it or thinking about incorporating that into their practice, thinking about what's the best practices for what you've done with your team and looking at some community standard comparisons, and then talking about success stories and pain points. All right, Ben, go ahead.
Everybody see my screen? Okay, so Menti just started off with some instructions. So either two ways, go to menti.com and enter the code 732 and the one you see there, or use the QR code on your phone. I'll link you right up. So I'll give folks a couple minutes to get that all set up. I'm really loving this Menti thing, and it's free. All righty. Unless I hear dissent, I'm going to go forward. So first question, are you currently providing pediatric CoCM or planning to launch a new program? Okay, so a lot of folks planning. Excellent. Okay, 10 and above. Interesting. All righty. What age range are you serving or planning to serve? We already have one answer, 10 and above. And then, oh, interesting. That's the approach I took. Any patient the pediatrician sees. That involves both diagnosis, severity levels, and age. All righty. And what are the biggest pain points and or successes? Everything's right down the middle, neither one. Okay. Excellent. Well, Laura, that looks exactly like what we were talking about, doesn't it?
Sure does. This looks like our leadership conversation a couple weeks ago.
Excellent. All right, I'm going to pass it back off to you, Laura. Oh.
All right, let's jump right into this question here. Those who put in some answers, or even if you haven't yet, share a little bit about pain points and or successes.
I hate to refer to successes in terms of a failed program, but
Out.
we did have a pediatric pilot for CoCM, which didn't survive the pandemic, for various reasons. But I think one of the successes we had was really incorporating triple P into the program, and that was a very good positive step to helping parents manage their children's behaviors and stuff. So I found that a nice tool in the tool belt.
Talk a little bit more about, what led to it not continuing. And also, I would love to hear a little bit more about the triple P approach and how you used it as part of your CoCM programming.
Well, two questions. Well, first off, it was ramping up just when COVID hit. Outpatient pediatrics was especially hard hit during that, and nobody was willing to accept any sort of additional risk. In the midst of all this, also we had a licensed clinical social worker in the role, and she went on maternity leave during that period of time too. So there was a lot of interruptions and fears and stuff. And even though we had the numbers to support that, it could be done. People were not very risk adverse at that point, and so it got folded up. But did some good work, had some nice outcomes and everything. But I it pains me. I'm by the way, I'm a child and adolescent psychiatrist, so I was the consulting psychiatrist in that role. So, but we're rolling it up again. So we're trying to roll that out with, ironically, at the same clinic that didn't sprout before, and then with some other clinics, and looking at trying to learn from past things and kind of bootstrap it across multiple pediatric clinics in our healthcare system.
Sounds like the infrastructure was more the issue with kind of some of those pieces than the interest, which makes it good for the next stage. What age groups are you serving?
Well, it was six on up, basically. Yeah.
Could you talk a little bit more about that? Because that was one of the things that came up in the mentee. It came up when Ben and I were discussing along with Monica. It's hard sometimes to set up for that 6 to adolescence CoCM compared to the adolescent. How have you approached that?
Well, the first thing was adopting some measurement tools. And what we did was use the parent promise tools for depression and anxiety, and also used the SWAN scale for ADHD. I dislike the Vanderbilt because it can't be scored like the PHQ-9 or GAD-7. There's no score to shoot for, right, coming out of a Vanderbilt. But the SWAN scale for ADHD I found to be very helpful because it does have norms and numbers to shoot for and everything. So, so 6 on up, we had the scales, normed out for. So we were using those on forward. We didn't use any self-reporting except for the adolescents.
That's a great point.
Yeah, that's great. In the project that I ran, we did 4 and above, and we used the pediatric symptoms checklist for those younger kids.
Other, group member perspectives. There's a lot of different pieces we could pick off there from what Dr. Clark shared. Any other perspectives, pain points, successes?
Hey, Laura, this is Danielle from OMH. I we'll give a little context. So we have about, I'm from New York State. We have about 380 practices now that provide collaborative care. Some of them are treating pediatric and family practices. So generally they are serving the 12 plus age range. But we're also a PIPIC grantee, and our PIPIC SAMHSA grant project is focused on pediatrics in collaborative care and pediatrics, which obviously but just kind of sharing that for the rest of the group. So we are having similar struggles at this point with the scales. We're finding that it's challenging to figure out which scales we should be using in that younger population. We're open to expanding if the psychiatrist is comfortable with that to that 6 to 11 group at this point. But it's difficult to find scales that everyone's comfortable using and that are efficiently done in a primary care space, because some of the other scales that people are suggesting take a lot of time. So I'd be just curious what other folks are using. It's interesting to hear about the SWAN. And the PSC is something that we're considering too, but it's, kind of nice, refreshing to hear that this is a challenge that's experienced across the board at this point, because it's something that we're actively having conversations about and working through as part of our grant project.
Yeah, Danielle, it's like Groundhog's Day because literally it's just
I
a
know.
week ago. So I'm a New York State-based general psychiatrist, and I'm really fortunate to be part of that grant that Danielle is talking about. And we literally were just talking at our last meeting about the problems with the serial administration of Vanderbilt's, in addition to the rating pieces. So very timely.
Yeah, one thing that's come up that I'm curious how other people are handling it is the frequency of the tools. So right now, in New York State, we do have a requirement that there must be a symptom monitoring tool completed each month, mostly for the fidelity to treatment to target. That's, where the background of that came from. But has anyone tried or piloted any flexibility in how frequently scales are completed, or generally are you still trying to stick to that minimum of once a month in the ped space?
So Laura, can I jump in on this unless anybody else wants to? And forgive me, I don't want to try to appear like I'm advertising for a company, but so I worked with Mira. They have a registry, but it was based on a measurement-based care platform where they have 450 different scales, and about half of those are pediatric. So what we did is we organized sort of an initial sort of set of questionnaires, and that included, depending on age, like Dr. Clark said, pediatric, the older kids would take some of them, and then we had ones that went out to schools and also parents. So we had this sort of initial phase of scales depending on the diagnosis or suspected diagnosis, and then we would trail it off so we didn't get user fatigue, back down to sort of that once a month, based on the treat to target. So it was multifaceted, and then if the psychiatrist or the team wanted a different scale, we could add that on as well. So like say there's a bipolar concern, we could add another scale on just by sending it out. And it all went out by text or email. And then there was about an 87% completion rate.
Wow. Yeah, that's helpful. We've actually been working a little bit through Verna with Jill Donnellan from Mira. You probably are familiar with her, advising on some of our guidance that we're hoping to put out for the younger ages. But yeah, that's helpful. That's interesting to hear.
Awesome. Nicole, I saw you come off mute. Do you want to share anything?
Yeah, sure. Just speaking to the question about kind of a variety in cadence for applying those validated measures. While the goal that I've always had is to, at minimum, apply those measures on a monthly cadence with patients and other models that I've worked in. I have recently heard about a little bit of flexibility. I know every state, especially through Medicaid, has some specific guidelines that you may need to adhere to, but I have heard a little bit more flexibility in general guidelines, stating that if you were to miss a month, for example, maybe it's inappropriate to apply an assessment 1 month because of something a patient reports and you need to pivot in that session, or I don't know, you do a bunch of work and you anticipate getting the screener in a session and then the patient misses the session. There's being some flexibility in the fact that you could still bill for that month, but you want to make sure that on a regular cadence you are applying those measures. It's just that on occasion, like if you miss a month, it's all right. So I've heard a little bit about flexibility there, and I thought that was interesting because I do think there are occasions in care where you do need to pivot, or you need to pause and be human and engage with the patient where they're at and not just throw a screener into the conversation where it might be inappropriate. I haven't been able to roll it out in practice because I heard about it after I left that care delivery with my patients. But I do think that it's something that's people are starting to talk about a little bit, and a little bit of flexibility. So I'd also be curious to see if in the New York guidelines, if it really specifically dictates that it has to happen every month, or that in general you're supposed to have that regular application of the measure, and if it's a little bit less specific. There's
That's an
Yeah,
awesome call out. What
it
about
is.
medical administration? That's another thing that comes up, like you didn't do the full screener, but maybe you did some measurement-based tools. Anything about that you've seen or heard about? You, Nicole, or others?
I've definitely, in my care, have seen individuals kind of pivot in regards to what measures they're applying. Typically they aim for the PHQ 9087, but they might use something alternative one month and count it. That, in my opinion, though, it kind of takes you away from that being able to monitor the progress over time if you're pivoting in different screeners. I mean, it is good to get some indication on how your patient is doing, but you really want to be able to track over time how they're doing. So I think it's all about, how you design that and making sure that you're at a minimum gaining the data you need every month to be able to make decisions and work with your patients over time and treat to target. So I think that's a tricky
Yeah.
question.
No, it's a good point. It's kind of helpful for us to think through. I know that in our New York State regs, we developed them before the CMS final rule on collaborative care. So unfortunately, it does explicitly list that there must be a clinical contact that happened during the month, a face-to-face visit with a licensed provider within 90 days, and a symptom monitoring tool. And I'm pretty sure it says was completed. But the partial question, Laura, I'm gonna think about. I'm gonna really pull that language from our state plan amendment. But it's something we're just thinking about with the flexibility that we know is required in pediatrics. We know it would take a while for us to update any type of regulatory state plan amendment, things like that take a lot of time, especially right now, as all of us know. But it's something we're just thinking about because the goal of our grant project is really to try to investigate some of the barriers and facilitators specific to pediatrics. So if it's something that comes up and is worth the squeeze, as they say, I think it's something we definitely consider.
And I just want to say a shout out of just how wonderful it is working with you and the OMH team. I mean, this is really wonderful to have the collaboration, and these sort of conversations are one example of just the appreciation I have working with you, Danielle, and your team.
Thanks, Laura. Same for you guys. We love having you as a partner.
Thanks so much. Other perspectives, pain points, successes.
I guess one thing I did want to throw out, and maybe this is general knowledge by this point, but those briefer sessions with the adult, as you see documented in the adult population, are extended to pediatric. And I don't think there's any way around it because you're dealing with children and with patients and stuff. So, these brief half hour or less, encounters, just didn't play out in the pediatric realm. So it had to be longer by force, but that was my experience, at least.
Dr. Clark, can I just expand on that? Do you find that sort of through the episode of care being continuous? Like I always think of collaborative care in like three parts. The first is like engagement and goal planning, but the end 2 months, there's those shorter appointments could be very useful in that sort of late stage of an episode of care. Did you see that?
Yeah, I mean, as far as the tapering off, I guess I was more not thinking about relapse prevention type of period of care, but more the active treatment that just takes longer than with adult patients. Is that was my experience, at least.
Yep, I echo that piece. And it's also a little bit different sometimes, some of the content, because you're going to be doing more care coordination in some situations with school, with family, the consent process. Definitely the beginning part, there's a lot more upfront needs. Other perspectives, what are others noticing related to the cadence, the timing, the length of check-ins in pediatric CoCM?
This is Jody, and I don't know that I can add much because we're new, but I want to say one thing quick, germane to the discussion about measurement. Neftali just put this new measurement sort of repository out through CFHA's page as kind of a conglomeration of ideas from the measurement-based outcomes SIG and the research and evaluation committee. And I just used it while we were on the call and asked it, like, what should we use to measure outcomes in pediatric CoCM? And it came up with everything we talked about, but we didn't talk about the child outcomes rating scale, which is one we're using. And that's all in the bot if you want to go play around with the bot. But the more targeted to the topic of these follow-up calls and conversations, our team was discussing this morning sort of how to script around scheduled calls and who am I calling? Am I calling the kid or am I calling the parent? And we know that, like, just from a nuanced perspective, every case is going to be a little different, and some where parents are really not functioning in an effective manner, and we're struggling to get them on the call. There may be some merits to just calling the teenager. Other times, parents are going to be in a really good position to coach kids through some stuff, and then they're going to be really helpful. But, like, how are people kicking that off? How are people are people starting out with, I'm going to talk with both of you on these scheduled calls? Do care coordinators go out of their way to kind of meet with everybody and do family calls? How are other people structuring that in the beginning?
I don't have a specific protocol for it or anything, but I kind of try to gauge from the referring pediatrician what their sense is if it's not clear. But I look at the referring, the note from the office visit with the pediatrician where they generated the referral. And that oftentimes gives me a clue as to even who seems to be voicing the bigger concern, especially when the kiddo is an older elementary age kid. With really young kids, it's, I would say almost exclusively that I contact the parents, I talk to them, and sometimes they're surprised. Sometimes they think that I'm going to be meeting just with their kid and fixing everything. And so I often will say, well, I'd like to talk to you first so I can find out what's going on and what you would want, what you're wanting to work on. I have a general idea from the note. But then as the kiddo gets old, when I have older kids, it really depends. Again, sometimes with teens, I usually strive to meet with them, and I really kind of just transparently talk about that part too. And I say, my hope is to make a goal of what you want to work on. And if the parent is the person who's more motivated for the change, then I'm probably going to be working with the parent. And I might even say that. I've had parents bring their kids and the kids like, I don't want to be here. I don't want to talk. And I say, that's fine. You don't have to, but then I'm going to be talking with your mom or dad or whoever your grown up is. And then that ends up working fine. Even with confidentiality, I'm pretty transparent and clear about how that works so that they don't have any surprises. But I think setting up the expectations from the start about what the parent and kids could expect to have happen, and also that we can be flexible about it, right? It's not whatever we decide at the beginning isn't set in stone. But yeah, I think gauging it based on the referrals sometimes can be the most helpful way to kick it off. And I try to really emphasize that from the start, that my hope is to help treat something. My hope is to help them meet a goal, so that they understand why I might be asking them questions that I'm asking someone.
Christina, can you share for the group a little bit about your background? You've got such great IVH and CoCM Peds background. Could you just share a little bit of that?
Sure. So my degree is in marriage and family therapy, and I've been working with kids, not completely exclusively, but predominantly in my career. And so the reason I'm doing that now, we launched collaborative care here at the clinic at this particular site first. So I was the first one doing collaborative care in our entire clinic setting. And so from the start, we started with the AIM Center, and had them with us for a year so they could help us implement it. And then when we figured out that it was working, we decided to expand pediatrics specifically. So now we have pediatrics well, we're recruiting, but technically at all of our settings that have a pediatrician, we would have a pediatric collaborative care manager. We also have some for adults. So we're trying to get all of it covered. But yeah, my background is mostly trying to develop the program. And one of the pain points that we used to have, but I'm actually kind of glad we had, was trying to separate ourselves out from the behavioral. We have a really robust behavioral health department. So we have full therapists, we have psychiatrists, we have adolescent or pediatric psychiatrists, we have adult psychiatrists. So we have a really good resource in that. But it kept defaulting that we would just kind of be the same thing. And so that's been my biggest task.
And I see you put in the chat a really nice comment about how you do brief versus longer. Could you just speak a little bit to that?
Yeah. It's actually something I learned last year at the CFHA conference when I went to Jessica Lyons's talk about counting minutes and stuff like that. She's with Mira as well. And I just was really it really made a big difference in how I see what we do, rather than falling into the trap of making everything a session like a therapist would, really considering what I'm doing as touch points or check-ins. So, and this was reaffirmed when I had a quick call with Verna as well one time, just to ask her some questions. And she had said, remember that you could do 5 minutes every day, and that would be part of treatment as well. It just has to depend on what your patient needs. And I love that flexibility that we have in collaborative care, that, I don't have to bill it as a session. I bill it as the work I'm doing with them. And so, yeah, it might be, I just talked to a patient's parent yesterday, and, I'd seen the patient a couple of times. We decided it'd probably be more helpful for me to help the mom with some parenting tools. And so I'm going to send her some stuff through my chart, but then I'm also going to call her and check in on to see how those are going, and, treatment to target. So pivoting as needed so that we can get to where they want to go.
Thank you so
what you're
much.
saying
That was
is
super helpful.
Flexibility. It's all about flexibility
Yeah.
and doing what the patient needs. I often think of it as building momentum, where if I can, have a problem list of 3 or 4 things, or maybe medical issues, mental health issues, but then if you can conquer 10% of it, you've engaged that patient, and then you work on the next 10%, and it just builds and builds and builds. And if that means working with a parent, that's great. If it means working with some of the school folks and talking with them, that's super important as well. So building momentum
And
Yeah.
that's one advantage. It's like the opposite of a pain point in peds that I find, is that it's hard to streamline something, but since we have to be so flexible, we actually sometimes get a much more rich picture of what's going on for the kiddo if we do get to go to school. Like, I attend Zoom meetings with teachers and stuff like
Yep.
that, and talking to the parents, and hearing hearing about, and then their cousins did this, I just get a much broader picture of what's going on with this kiddo than if I were working with an adult. That's harder to achieve because you can't just reach out to their workplace or whatever.
Yeah, and also when you're doing the measurement-based care and with adolescents, a breakup or a bad grade could escalate to PHQ-9 and you think it's an emergency, but it's actually it's going to be fine tomorrow. But there's a lot of information, attendance, behavior, grades, all give you incredible information and predictive information.
That's a great segue into another stuck point that's come up. How are others navigating the timing of check-ins? So a common issue that I've experienced and then also heard come up with PEDS CoCM is limited, kind of ability to check in during the school day, lots of interest, mostly after school, more so than before school. How are people navigating that? What are people finding related to the timing in the day for this population, especially compared to adults that maybe are more available?
Can I jump in on this? I don't want to dominate, but Christina's, the flexibility. If you're working with kids from like age 4 and up, because it doesn't have to be direct contact with the identified patient, you can work with parents. Like I think Christina was mentioning, work with parents on behavioral plans, or they're available. And every private practice clinician says 11 to 2 is their bewitching hour. They can't fill that, right? And that's when you put in, a behavior management course or a behavior management treatment, plan with the parent or that parent meeting. So it gives you a lot of flexibility. And catch kids when you can catch them and how you can catch them. So if that's 11 o'clock at a guidance counselor's office, so be it.
Yeah, that's helpful. We've also had some of our grant sites experimenting with flexible hours and remote care managers. So I know that one of them that I think has 4 sites participating now is requiring at least, I think, 1 evening and 1 weekend morning in the job description. So they have them, available to make some phone calls and outreach on the weekends. And then some of them are also using interns to try to cover some evening hours for some of the care coordination aspects too. But this has come up a lot across our sites. It's a major challenge.
Great creativity. How about others?
Just kind of echoing a little bit of what I've already heard said. It's been a combination of working with the staff that we hire in the BHCM role to have that flexibility where possible. So, kind of pre-establishing before they even start in the role a shifted schedule, whether that's a 4-day work week where they work later days, but they have Fridays off or something like that, or a flex schedule where maybe a couple days a week they start later and end later. There are also individuals that are looking for that scheduling, so that can really be valuable individuals to work with, or people that want a big gap in their day so they can do certain activities in the middle of their day. All sorts of creative solutions there to scheduling. I do think it is a unique conversation when hiring though, and really making sure that they understand that commitment and are comfortable with it. Especially if they're on site. I was working in a remote environment, so that conversation was a lot easier, hey, turn your computer on one time of the day or another. But when you physically have to be somewhere, I think that demand's a little bit heightened. And then just creative solutions like working with schools sometimes to be able to maybe speak with folks in maybe the guidance office or in a private space during maybe a lunch break or something like that. But really just wanting to be mindful, what that might be taking away from that child's kind of like ability to engage at school and things like that as well. So, but sometimes those creative solutions are the only way to get a private space with them and be able to engage during the day. So, a couple of different creative solutions that we've tried over time.
Great ideas. Yes. Liz, I see you came on camera. You want to say something?
I do. Thanks. This is Liz. I don't work in a collaborative care program, but I work with a lot of practices supporting collaborative care programs. And on this topic, but sort of opposite problem, I feel like I am working with a lot of practices whose behavioral health care managers get in the habit of just scheduling 2 30-minute blocks for their patients enrolled in the program throughout the month, or even one 1-hour session. And they're essentially doing like monthly 1-hour therapy visits, but billing collaborative care. And we're missing the value of the model when they get kind of stuck in that scheduling routine. And so I was just curious if anyone has tips on coaching care managers on the flexibility that Christina was describing.
We had we're still in implementation mode, but one of the things that is something that came up a lot because all of us came from a background of doing therapy. And so we absolutely all would have a tendency to go towards that, to default to doing therapy sessions instead. And I don't know if this is the most helpful one, but some of us responded pretty well to this idea to really, first of all, scale back the idea of an intake, not even necessarily thinking of it as an intake, because I think that sets the stage for it being therapy and really broadens the idea of like all the things that you might want to work on, and rather say, okay, it sounds like you're having a hard time when so in that initial session, or even any few first follow-up appointments, that can really be a half hour, maybe even more, but really setting the expectation by saying, okay, here's the goal. How will we know when we're at this goal? Here's what I think we should work on, and just really setting the tone of it not being a therapy space, but really more of a therapeutic way to reach your goal. Or also sometimes this comparison has helped where we might say, okay, imagine if a PCP were sending the patient to a physical therapist for treatment. How can we structure what we do? I mean, of course they have sessions as well, but maybe they're giving homework to practice or something like
Home
that.
exercise program.
Yeah, right, exactly. Yeah, a home exercise program. So what could we do as our equivalent?
Like that.
I often think that the kind of initial starting point of that problem is oftentimes when how the doctor then describes the program to the patient. So if they're saying psychotherapy, that's the way they're presenting it, and that's how the community, understands it. It's going to be 50 minutes once a week. And so that's the expectation is set up. So maybe we were manipulating our doctors a little bit, but we had a script for them to say, and the script was, clearly had language that this was a team approach, that there's short term and, all those things. And that set the expectations up a bit more. But for the clinicians that I worked with, I often say, you're more of a detective than a clinician, or both. You have insight that most clinicians don't have, where you have the medical record and the medical, doctor and the psychiatrist. You play detective and find ways, get goals started, and then, like I said before, knock those goals down.
I feel like we still have a lot of good room for improvement on that wording related to the role, because counselor and therapist don't fit, but they're also more credentialed than a coach or a trainer. So I feel like this is an area still we've got room for improvement in terms of really highlighting the role with language like treatment to target. We're not doing counseling, we're not doing therapy. You're going to work with someone like a behavioral health coach, setting goals that you're going to be tracking on and working to improve. So I don't know what other people are using for that language, but just wanted to call that out, that the language matters. And that's another area that we run into challenges with expectation management.
This is Kristen McGregor. I was also going to say, resist the urge for a standing appointment. I think that also, it doesn't allow the necessary dose and titrate that we're also trying to do in collaborative care. And so it sounds like I forget who asked the initial question, but some of your therapists are sort of allowing for this, but I'm always free on Tuesday at 2, and like that's great. And it sort of socializes to that's just your standing visit as opposed to every single session reevaluating how you are and whether or not you actually need an appointment in 2 weeks, or maybe we go out a month.
Excellent point there, Kristen. I think that's part of the expectation management piece. It's not there's the language, and then there's also the behaviors, and setting our behaviors as a model. Very helpful. Other thoughts or questions? Ben, could you share a little bit about your publication? I think you have some really relevant pieces there that would be helpful for us just to talk about.
Well, I had one publication published in 2024 in the Psychiatric Times article. I think it's an online journal. And that described the pilot that we did in Exeter, New Hampshire, where we went down to H4, and then we really worked with all different diagnoses. We kind of had a policy to work to shoulder with the doctor. I think someone had been, mentioned in the Menti poll something similar. But the thing that we did a lot very differently is, and I think Christina does this too, is met with school districts, went to special ed meetings, got data about how they were doing, and it truly filled out a picture, like Christina was saying, of more in-depth knowledge about the patient. So there's another application or article that's being reviewed for publication about the partnership with Mira, and as you mentioned, Jessica Lyons was there with me, and how we used a sort of hybrid model where we had a licensed clinical provider and also a care manager in the same team. And what the interesting part of that is that it was an in-clinic operation, but we really wanted to be available to the doctors 100% of the time, so that we could capture every referral and communicate with the doctors about treatment plans and things. And so when the clinician was seeing with somebody for collaborative care, we build psychotherapy codes too. The care manager was out on the floor, and then vice versa. When the clinician or the care manager was available, the clinician was available, the care manager would then go to school meetings and get resources and do things in the community as well for that patient. So it was a pretty dynamic approach, and really was financially sustainable. So we don't know if that's going to get published yet, but we'll see.
Yeah, I think, that call out about the additional time and additional smarts and needs, it can be done within one care team member, or this need to maybe define additional care team members for pediatric CoCM is a really cool thing to think about. I have a question here that came up. So we had a teen who was wondering if they could do collaborative care purely by text. They said that they felt more comfortable doing all check-ins by text, didn't want, to have telephonic, didn't want to have telehealth. So what are folks' thoughts on that?
I've had similar requests before, from adults too, actually. Especially in a remote environment, we had a lot of secure messaging avenues for our patients. Um, we tried to be as flexible as possible because we did want to meet the patient where they were at, but we also wanted to be able to verify that they're safe and that, um, that they're doing well. And there's just some things that are very hard to identify via text that if you can at least have them a voice on a phone, you can gather a little bit more information about how a patient is doing. So I would try to negotiate a little bit while I would permit some text sessions, because it does seem to be something that is permissible through the way that collaborative care is built. I would be mindful about how often I would try to say maybe like, every other session, or hey, maybe we have a 10-minute check-in and then we continue the session via text, and kind of some creative solutions there. But I would have, I don't think I ever agreed to 100% of the sessions being via text. Typically I'd want to be able to get some kind of ears or eyes on the patient at some juncture. But there's a lot of instances in collaborative care where you can engage via text and minimize certain instances on the phone. For example, the measures, maybe being able to send that to them to fill out themselves, or they could text you the responses to that, for example. But yeah, I think it would be tough to do all of the sessions. I don't know, maybe that was just me being a little insecure with that, but
No, that aligns with me. How about you, Elizabeth? I see you came off.
Yeah,
mute.
I have a lot of thoughts about this. So I'm a child and adolescent psychiatrist, and we have an integrated care that's not program in pediatrics, that's not full collaborative care for a lot of challenge reasons that I think Dr. Clark had, like really similar things. And I have to say, when I hear somebody say they want text, we on the medical side, we hold a lot of the liability for the organization. And we have to think about what standard of care is. And if standard of care for a teen with depression or with anxiety that's creating a situation in which they're practicing anxious avoidance is, first of all, like getting a proper mental status exam, having proper therapeutic engagement, ensuring you're actually talking to the patient and not their parent or their friend or their sibling, and giving, if it's anxious exposure, giving exposure to the thing about which they have anxiety. Then agreeing to do something by text just because it's there and available is not practicing standard care and opens up to a lot of liability, I think. So I think understanding the diagnosis and the reason is really important. Meeting the patient where they're at to some extent is like what we do, but also sometimes like what we're called upon to do in mental health treatment is actually to push somebody and to provide safe scaffolding for them to be able to engage in a way that is therapeutic and is going to help them in their recovery. So I would have a lot of concerns about doing it. It's definitely something, if any of my clinicians that I work with, any of our clinicians in our program was to ask about, the question would be a bigger one about exploring diagnosis and thinking about whether actually this individual needs a higher level of care or something else is going on here that's treatment interfering.
Thanks so much, Dr. Allen. Excellent call outs.
Could I add one more part to it? And this is purely me. I'm not sure if I could follow along with the text train as easily as teens can, or even understand all their language as well, how they speak on text, which is often different in person.
Absolutely. That brings also to the piece of child protective services, other sort of pieces like that, as we're talking about medical legal responsibility and additional concerns for this population. How are folks navigating those pieces that sometimes can enter in? I've heard some consulting psychiatrists, they'll make that a running agenda item of determining if there's anybody that there's concerns like that. How are others kind of looking at that within this population and navigating those sort of pieces?
One of the things that I hear, I think might be related to that, Laura, is teenage privacy around things of sexuality or drug use and things of that nature, and how do folks deal with that? That's often very, very hard. In the work that I did, we developed a code word that would indicate with all the providers that it was adolescent issues. And that was highlighted in the EHR and an option, so it could kind of redirect where that information was going. And if it was on, what's the law called? It was freedom of notes. If it was going through portals and things of that nature.
Here in Washington State, parents can't access their kids' notes as soon as the kiddo turns 13. So that's a little easier in those terms. I think though, what does come up sometimes, and this was a good example of a patient that I'm sharing with a family doctor. So I don't actually work with that doctor as often, but it's a pediatric patient. And the kiddo disclosed to this doctor as well as to me here and there a little vaping, and he did get caught drinking. And so he's 15. And so the doctor and I coordinated on, is that something that mom knows about or not, right? So that, and it's hard, and the same mom understands about confidentiality, but is like, is there any way that I can know what's going on? And that does make it a little bit more tricky. But in terms of reporting like CPS things and like that, That's actually a really good question, because that's not something that we've had happen often enough, I guess, pretty fortunately in our situation or in our settings, to where it required us to kind of come up with something, but it's something to think about where, how do we communicate that? I think we do so much when we document what we talk to patients about, we always CC, unless it's like I left a voicemail, we always CC the PCP on our notes, and to minimize them having to read through everything. Not that our notes are always so huge, but we have a place they can zoom in on so that we can, say, here's an action item for you. And so sometimes if we did, I think that's what we would do, is just note, hey, just so you know, I had to make a CPS call or something like that.
Excellent discussion today. Any closing thoughts, closing questions from the group?
Can I just add one more thing to the measures? And real quick, we added the caregiver strain index being filled out by a parent. And I can't tell you how important that was. It was an incredible addition, because you could see, sort of the stress level of the family from the parents' responses. And it was often a leading indicator of, positive reactions to treatment plans by, the parents' perspective, and rounded out a whole different source of information. It was pretty interesting.
What was that one called?
What was that again?
The caregiver strain index. It was originally built, I think, made for adult parents taking care of elderly, but there's a one for parents working with kids.
Awesome. So many pearls today. All right, everybody, we will have our meeting next month. I know it'll be tough with it being 4th of July week. So if you're able to make it, that's awesome. But we also understand it's that time of the year. All right, everyone, have a great month, and we'll talk soon. Bye.